Get a recording going. Well, hi, everybody. I hope that the captions are going to work. They have been reset, although I'm not seeing them on the screen. So worried a little bit about that. But it is what it is. So we're going to proceed. So welcome, everybody. This is GW Center for Integrative Medicine podcast and open house and YouTube recording. And today we're going to be talking about mold. We're going to be talking about food and mood and brain and memory and how all these things are connected. And the speakers for today is the current person who's highlighted is Brianna Darling, who's our Recode coordinator and nutritionist and a health coach. And also Dr. Yeker, who is, I'm gonna highlight them now. Dr. Yeker is our mold expert who's a fully trained in Shoemaker's protocol. He's also a doctor of chiropractic medicine, and each one of them will be telling us about what they do, and we're going to be talking at the end as how all this is integrated. My name is Dr. Mikhail Kogan, Misha Kogan. I'm a medical director for Center for Integrative Medicine. And with that, without further ado, let's jump right in. So in 2 words, I'm going to tell you why we decided to do this. So we historically have been seeing an increased number of patients in the last couple of years who have what we define as SIRS, and Dr. Yeker will give us a detailed information about that. And the SIRS is our chronic inflammatory response, is a type of systemic inflammation that's often triggered by chronic mold toxicity. And for many years now, we've also been aware that some of the cases of Alzheimer's disease are actually not an Alzheimer's disease, but a chronic mold toxicity, as often described as inhalation Alzheimer's by Dr. Bredesen. And so with that, we felt like there's a big link. And since Brianna and I have been heavily involved in the Recode program, and at this point we have over 50 patients, with a significant percent of patients being, well, I wouldn't say cured from Alzheimer's disease, but completely reversed or partially reversed or arrested in the progression of Alzheimer's disease. So we felt that this talk would be very timely and also very, very needed. And so with that, I'll pass it on to our experts, I guess in no particular order, but I guess since I have Dr. Yeker on the spotlight, maybe we'll start with that, but I also gonna spotlight Brianna. And oh, look at that. Now I can figure out how to spotlight all of us together. So thank you very much. And again, I do apologize. I did set up the automatic captions, but I'm not seeing them going, unfortunately. So for the person who asked me to do that, I do apologize if it's not going to be on the recording, but we've tried. So you guys take it over. Jonah, you muted.
All right. Yeah. Thank you, Dr. Kogan. I certainly appreciate the opportunity to join in today and share a little bit about mold and mold-related illness and chronic inflammatory response syndrome, and how all of this correlates in and it has an impact on brain health and on cognitive decline, Alzheimer's, and dementia. And then, of course, Brianna is going to be sharing as well, getting into the food aspect, the dietary aspect at the same time. So I'm going to go ahead and share my screen. We've got some slides here that we're going to share. So bear with me just a moment here. We'll share the screen. All right, so getting a thumbs up here. So we're talking about food, mood, mold, and brain health, really, how all of this impacts brain health. So I figured I'd start with just kind of an overall introduction to chronic inflammatory response syndrome. So I don't know how many people here are already familiar with Recode and the work of Dale Bredesen and the work that Dr. Kogan is doing at GW, at the Center for Integrative Medicine. But what Dr. Bredesen pointed out is that there's all these different types of cognitive decline. And, there's the type 1 that's inflammatory, associated with inflammation. And I believe it's 1.5, Dr. Kogan, you can correct me if I'm wrong, but I think it's 1.5 is associated with blood sugar, and then there's with blood sugar imbalances, and of course huge role in diet, so metabolic. And then there's type 2, which has to do with hormone imbalances, which will cause brain atrophy. And then there's type 4, which is toxic, and it is within type 4 that mold related illness lies. And in fact, in his groundbreaking book, The End of Alzheimer's, when he's talking about type 4, he even discusses mold and specifically chronic inflammatory response syndrome and the Shoemaker protocol, which is what I'm trained in. I've worked both personally and professionally with Richie Shoemaker for over 5 years at this point. And this is really what I specialize in my own work and in my own clinic and with GW. But so, when someone comes into the Recode program and, they're having any kind of cognitive changes, well, the first thing that has to be determined is what's the root cause? What's the source of these cognitive changes? And part of that is ruling in or out chronic inflammatory response syndrome as a result of exposure to biotoxins. So what is it? We refer to it as SIRS. But what is chronic inflammatory response syndrome? It's exactly what it sounds like. It is a chronic inflammatory condition, but in this case, it is the result of ongoing exposure to what we call biotoxins. So a biotoxin is any kind of toxin that is that is living, so to speak. So mold is going to release what we call mycotoxins or biotoxins coming from mold, but bacteria also can release toxins and make people sick. And in fact, I'm sure many of you are familiar with the concept of chronic Lyme disease. And in fact, chronic Lyme disease is really at its core, it's chronic inflammatory response syndrome. It's just triggered by bacteria as opposed to being triggered by mold. And as we'll get into a little bit later, chronic inflammatory response syndrome can also be triggered from a viral infection. And this is really what we're seeing in these COVID long haulers, people who get COVID, but they don't recover from it. And it's because what's happening is they are developing this chronic underlying inflammatory condition. We refer to this as multi-symptom and a multi-system illness. And really what we mean by that is, at its core, what's happening is the brain is getting inflamed. So when we have ongoing exposure to these biotoxins, it will result in neuroinflammation or brain inflammation. And when the brain gets inflamed, well, it just so happens that the brain is controlling everything in your body. So all the other systems, your immune system, your circulation, your digestion, musculoskeletal, cardiovascular, all of this is being controlled by the brain and by the nervous system. So if the brain is having dysfunction, it's inflamed, well, it's going to roll over into all these other systems. So now we start developing digestive problems, and we have issues with circulation. And because our immune system's dysfunctional, we start developing autoimmune conditions. And, we might get chronic pain from the buildup of inflammation and lactic acid in the muscles and joints. So it's multi-system. And because it's multi-system, we're going to get all kinds of oftentimes random symptoms that are seemingly unconnected, but in fact, they're quite connected. I would argue, and I probably wouldn't have to argue very hard, but this is potentially one of the biggest health issues that is affecting Americans today. And the reason for that is because, we estimate that a minimum of 50% of all homes and buildings have at some point been water damaged. They've had a leaky roof, or maybe a flooded basement, or maybe the HVAC was leaking, which we just had this issue in our very home this past week. So HVAC's leaking, faucets leaking. And in fact, I would say this is a massive underestimation. You show me the home or building that has not had a faucet leak or a toilet leak or something of that nature. So we're looking at all of these homes that when the building materials get wet, not only do they potentially grow biotoxins like mold or bacteria, which sets in within about 48 hours of it getting wet. But it also just releases all of these toxins where, all of these building materials are primarily toxic. And when they get wet, these toxins also get released into the environment. So when you combine this with the reality that about 25% of people are genetically predisposed to not be able to detoxify these biotoxins, we're looking at a massive number of people. I think it's estimated about 40 million people in the United States alone who are sick with chronic inflammatory response syndrome, and they're not being diagnosed. They're being misdiagnosed with things like chronic fatigue syndrome or fibromyalgia or brain fog. And oftentimes these folks are just dismissed as being depressed because no one can find out what's wrong with them when really they're just not running the right labs to begin with. So we've got all these people who oftentimes look healthy and their labs might even present as healthy, but in fact, they're really, really quite ill. So when you think of mold and mold-related illness, for the most part, there's a huge genetic component. About 25% of the population is going to be predisposed or more likely to get sick from exposure to mold or any kind of biotoxin, which again, this is why not everybody who gets COVID gets long COVID. There has to be that genetic predisposition that's going to set them up for that possibility. So as I mentioned, we're looking at about 40 million Americans going undiagnosed, going misdiagnosed. They're sick and no one can find out why they're sick. So, one of the ways that this starts to show up is, as I mentioned, is that there are it's a multi-symptom related illness. So one of the ways that we can screen for chronic inflammatory response syndrome is we have what's called a symptom cluster analysis. So all of these symptoms that you're going to see on your screen, they're all associated with mold-related illness and chronic inflammatory response syndrome. But of course, they can be caused by a whole variety of different things. As you look at the first box, diarrhea, abdominal pain, and numbness, well, a lot of things can cause that. It's not just mold that is going to cause those kind of symptoms. But what we're looking for here is that if you have a symptom in any one of these boxes, it essentially counts as 1 point. And so we're looking for patterns. We're not just looking for 1 or 2 symptoms. We're looking for a pattern of symptoms. And so, this can show up as diarrhea and abdominal pain and numbness, but it can also show up in the respiratory system, congestion, shortness of breath. Of course, this shows up in brain function, so impaired memory and difficulty word finding. Skin sensitivity, pins and needles can start to show up for a variety of folks. People might be disoriented. They might get a metallic taste or watery eyes. Difficulty with concentration. One of the hallmarks of mold-related illness is not only brain fog, but a very deep, persistent fatigue. So we're not just talking like a little tired. A lot of these folks are exhausted all the time. Joint pain, muscle stiffness, muscle cramps. So you're seeing that musculoskeletal aspect, blurry vision, night sweats, mood swings, anxiety, depression, even PTSD has been associated with brain inflammation. So, mold-related illness can certainly be a trigger for that. Weakness, headaches, light sensitivity, difficulty learning, dizziness, static shock, extreme thirst. I could go through all of these individually, but really the idea here is that if you have any one in one of the boxes, that's a point. And anytime you've got 6 points, then that makes it likely that your symptoms are coming from chronic inflammatory response syndrome. Now, we would, further go on to validate that with some additional tests, but that's just a quick way to screen. So if you're questioning out there, if you're like, do I have mold-related illness? Is that why I'm brain foggy? Is that why I'm so tired all the time? You can just take a picture of this slide really and just go down the symptoms. It's like if you have not 6 or more symptoms but 6 or more categories here, then there's a good likelihood that chronic inflammatory response syndrome could be a part of it. And then of course, because these symptoms are so wide ranging and can be all over the place, there's a lot of common misdiagnoses. So, anytime I have a client coming into my office who's been sick with, say, chronic fatigue syndrome and fibromyalgia for 10 or 20 years, it's a good chance that it's just been missed what they actually have going on. As I mentioned, Lyme disease is a common misdiagnosis, mostly because what will happen is that this person has chronic inflammatory response syndrome, but for someone who's got Lyme, they will not heal and recover until they also address the mold. So again, I see clients all the time who have been sick with Lyme disease for 5, 10, 15, 20 years, and no one's bothered to start looking at, potential exposure to mold. Any kind of neurological deficit, MS, Parkinson's. In fact, I just met with someone recently with MS, and in fact, labs show chronic inflammatory response syndrome. I've seen people with these really significant neurological disorders actually resolve when we got them out of mold. And again, that's not to say that that would be the case for all of them, but I think we're doing ourselves a great disservice if anyone's got MS or Parkinson's or even ALS, if someone's not looking to see if mold is at least potentially making these things worse. Digestive disorders, it's estimated that 80% of people with chronic inflammatory response syndrome have gastroparesis. There's going to be constipation, indigestion, bloating, heartburn, but inflammatory bowel disease, irritable bowel. It can show up as chronic allergies. Oftentimes people with chronic inflammatory response syndrome who've had it for long periods of time, they're going to start to develop all of these strange autoimmune-like conditions, Hashimoto's, attacking thyroid, lupus, scleroderma. I've seen all of these things improve when we got to the root cause of chronic inflammatory response syndrome. I think it's important to point out the mental emotional impact that this has on people as well. It's like we've known for decades how inflammation impacts all, and it's really at the root cause of all our Western diseases, like heart disease, inflammation. Diabetes has an inflammatory component. Cancers, there's inflammation oftentimes involved. Any kind of arthritis, like so many things are inflammatory, at least at the root. Well, we've now learned that this is also true of a lot of mental emotional disorders like depression, anxiety, even things like bipolar and schizophrenia are now being correlated with brain inflammation. It's the brain that's inflamed. And being that mold can cause the brain to be inflamed, it would make sense that it will drive a lot of those symptoms, even PTSD. And then, of course, the purpose for today's conversation, cognitive decline and dementia. Because if the brain is inflamed long enough, eventually it's going to start to degenerate and it's going to start to shrink. And we actually have a way of measuring through a brain MRI, looking for this inflammation and potential atrophy that can set in. Atrophy means shrinking of the brain as a result of mold. We can look for patterns that are consistent with mold versus Lyme versus a head injury versus PTSD and various other things that can cause physiological changes to the brain. So, this is very, very real. I didn't realize this until I myself got sick and had my own MRI, but oftentimes what we write off as being brain fog, if you hear someone using the word brain fog, well, their brain's inflamed. That's why their brain is foggy. Now, why it's inflamed might be another story, but one of the major driving factors, again, of brain fog could potentially be mold, Lyme, long haulers, COVID. If anything's, like I mentioned, if it's inflamed long enough, it will start to shrink. And that's when we start actually getting a label such as dementia or cognitive decline. So how do we diagnose it? Well, the first thing we can do, there's a quick means to screen for chronic inflammatory response syndrome. You can actually find this online. There's a lot of ways. Typically, I'll go to survivingmold.com. This is Richie Shoemaker's site, and you can, for maybe $15, get a VCS test. And it's a quick means of screening for neuroinflammation through a visual test, because when our brain gets inflamed, it will inflame the nerve going to the eyeballs and we'll lose our ability to pick up contrast. So for $15 and about 15 minutes of your time, you can screen for neuroinflammation. And when you combine that with the symptom cluster analysis, which will oftentimes come with one of these tests, but you now have from the slideshow. When those both are positive, when you have a positive ECS and a positive symptom cluster analysis, it's about a 98% likelihood that we're dealing with chronic inflammatory response syndrome. So this is where I would start most people. Let's just do a quick screening and see if we're even on the right track. Once that comes back, we're going to run a blood panel, and now we're looking at very specific, one, we're going to look and see if there's the genetic component. We're going to look at the inflammatory markers, and we're going to look at the hormones that get impacted once that inflammation goes high. So this essentially would confirm chronic inflammatory response syndrome. And once that happens, once we get a positive diagnosis, like here's what we're dealing with, well, at that point, we need to start testing the home for mold. We would do some additional testing. It's a swab in the nasal cavity for something called Marcons, which is an antibacterial resistant, it's an antibiotic resistant bacteria that will colonize in the nasal cavity. And then finally, I mentioned the MRI. It's called a neuroquant MRI. This is what we'll use to actually look at the brain. And we could even do more advanced genetic testing in a more complex case. But once the diagnosis is there, that's going to set off, okay, now we got to get all our ducks in a row so that we can actually start turning this around. And I would say that's, kind of one of the beauties of chronic inflammatory response syndrome is that we've actually got a solution. We've got a protocol that consistently works and has been shown to even rebuild brains on MRIs. People get their brains back, they get their energy back, they start to get their lives back. So it's like, this is a very difficult and very challenging illness to struggle with. Oftentimes it's very expensive because it requires sometimes remediation and potentially moving into new homes. And, so it can get costly real quick. And at the same time, I don't know that we can put a price tag on what it would be to get our brain back. And I can speak firsthand for that, having been through it myself. And in fact, I was so incredibly sick when I first had my MRI run. I had a doctor look at it and tell me that it was one of the worst MRIs they'd ever seen. And that based off that, I'd be lucky if I knew my wife and my kids within about 5 years. I was in my early 40s at this time. So, that was absolutely devastating, and it was completely petrifying. And it definitely initiated a sense of action. So I went through the protocol. I got out of mold exposure. I detoxified my body from the biotoxins, and then went in with the last step of the protocol. It's a nasal spray that we use to increase the hormones that actually repairs the brain. And within about a year of my recovery on a follow-up MRI, it had completely all returned 100% normal, not to mention the fact that I had completely returned and my brain was working better than I could remember in many, many years. So what are the treatment options for chronic inflammatory response syndrome? Well, essentially first we diagnose it, and then there's 3 stages of the recovery process. Stage 1 is essentially what we consider when someone shows up and they're in mold and they're not being treated. Now, stage 2 is they're out of exposure and they're on what we call binders, which is what we utilize to grab onto those mycotoxins in the body and to pull them out of our system. And then stage 3 is we're out of exposure, we're on binders, and now we're treating with a peptide called VIP that stands for vasoactive intestinal polypeptide. It's kind of a mouthful, but it's this specific peptide that's been shown to rebuild gray matter in the brain, restoring what was once a damaged brain into a healthy brain. And of course, this is something that to this day we're still told can't happen. You can't heal and rebuild brains. Well, we absolutely have case studies that show exactly that happening, me being one of those. So how are mold, SIRS, and Alzheimer's disease all related? Well, in a nutshell, mold will trigger chronic inflammatory response syndrome, and then chronic inflammatory response syndrome results in neuro or brain inflammation. And if the brain is inflamed long enough, we will start to have cognitive decline and we will start to have dementia. Now, that's a little bit different than Alzheimer's. However, it will just compound the whole situation. If someone's got Alzheimer's and they've got chronic inflammatory response syndrome, it's just going to expedite the process of the degeneration of the brain. So, addressing the chronic inflammatory response syndrome can go a long ways towards getting people's brains back. Differences between long COVID and chronic inflammatory response syndrome. Well, I would say there isn't a difference to our knowledge that really COVID is from a virus, and a virus is a biotoxin, and biotoxins trigger chronic inflammatory response syndrome in about 25% of the population. So, this is one of those things. Again, it's like if someone's got long COVID, they need a doctor who is trained in chronic inflammatory response syndrome and the recovery in order to fully recover, in my opinion. Similar and different causes. I think I already spoke to this. Mold, bacteria, viruses. Those are primarily the things. However, head injuries can trigger chronic inflammatory response syndrome. Any kind of significant stress or trauma, childhood traumas have been shown to be what initiates the switching on of that gene that many of us have that are associated with mold-related illness. So, usually when I look back at clients' histories, typically they got sick around the time that they had a significant amount of stress going on in their life. Maybe they were going through a divorce. Maybe they slipped and hit their head. Maybe they, were having a hard, working in a really high stress job. And then on top of that, they were also living in a moldy environment. So it's like when you add it all together, it's enough to push the genetic expression into a state where we start to develop chronic inflammatory response syndrome. Why do both long COVID and SIRS take so much time and are so slow to respond? Well, one, oftentimes I tell most people, look, it's going to take 12 to 18 months to recover from this. The treatment itself is probably about 6 months, but the other 6 to 12 months is all about just getting into a clean environment, because anyone who's got long COVID and anyone who's got Lyme, they're likely also going to have to get out of mold in order to fully heal and recover. It's very complex. And it takes time. It's hard. It is hard to get out of exposure. It's hard to remediate. It's hard to find people who can do all of this appropriately. And then, of course, there's the financial component. So, this is why I think at GW, we worked hard to create an environment where you have a lot of support. You can meet with people like myself and with Brianna, frequently, just to make sure we're hitting all of the checkpoints on the recovery, and that people don't get lost in the recovery, because that'll happen. People will disappear. I won't hear from them for months. And then, eventually they'll show up and they didn't make any progress because they just kind of got lost in the big checklist of to-dos. So, we've created a program that helps people navigate the complexities of this recovery and get the support they need to do it successfully. So it's not just one more protocol that they tried that didn't work, which is so frequent with mold-related illness. So many people, so many patients going from doctor to doctor to doctor, not getting the care that they need. Maybe they feel better for a little bit, but it never gets to the root cause. So we're trying to put an end to it. We want the mold-related illness to stop here. So I think with that, hopefully you guys are developing some questions and starting to put them in the chat. I'm going to hand it over to Brianna at this point. She's going to talk a little bit about the Keto Flex, the diet, some of the other things that are a part of Recode and the health coaching that comes along with that. And of course, I thank all of you for tuning in, and any questions you have about chronic inflammatory response syndrome, I'm happy to answer those on the chat. So Brianna, without further ado, jump in, and I thank all of you for tuning in today.
Thank you so much, Dr. Yackel. That was very informative. I'm very glad to have learned a few things of my own for SIRS, chronic inflammatory response syndrome. I would like to talk a little bit about the health coaching, and with the health coaching, that component that will be done within Recode. So I'm a nutritionist. I manage the diet, the physical exercise, and the cognitive exercise aspects of the program. With Dr. Kogan, I have helped manage the nutritional aspects of this program. So the primary diet that you have to follow with Recode is the Keto Flex diet. which is a spin on the usual keto diet, but with a few caveats. We do include intermittent fasting within this diet. Similar to the Mediterranean diet, it's very whole food, plant-based forward. Use a lot of fruits, a lot of vegetables, berries rather than larger fruits like bananas or mangoes or pineapple. You're trying to reduce the amount of sugar content that you consume in this diet while expanding on the fats and healthy fats component. So the goal is to get you into ketosis, which switches you from a glucose-based carbohydrate diet to a fat-based diet. It will help you it'll help basically all the components come together. The intermittent fasting will compound on the ketosis diet, which will be extremely helpful. We monitor the ketosis with a breathalyzer, with a biosync breathalyzer. We're trying to keep a moderate to high level of ketosis throughout the diet. In addition to this diet, we also include a fair amount of physical exercise and cognitive exercise. You both need to do a lot of cardio. You need to include a lot of strength training as well. Let's see, with the mindfulness aspect as well, you are encouraged to look into yoga or Tai Chi, because it is very important to keep a low level of anxiety and stress during this entire process, because the stress, the cortisol levels, if they're out of control, then the management of this entire program will suffer. It's really, really important to keep all your stress level down as much as possible. My approach to coaching this nutrition is a very personalized style. I try to get to know the patient, get to know their lifestyle as much as they can, tell me much as we can work with it together. It's very important to see what their interests are with the diet, the exercise, and the cognitive exercise as well, because there's not much point to pursuing this program if you're being literally forced to do something exceedingly out of your interest zone and exceedingly out of just your normal day-to-day life. You're not going to have success on this program whatsoever if you have to move almost your entire lifestyle over. The diet is difficult enough as it is. We're trying to bring together everything, just bring together well to try to support the patient in making this drastic lifestyle change. Now, when we are moving on to the Apollo reports, in order to evaluate how this program and how everything is moving together, we put this report together called an Apollo report. So we have patients take blood work every few months or so, every 4 to 6 months. Each one of these reports is dependent upon metabolic blood work. So you have a blood work such as like a CBC, complete blood panel, glucose and inflammatory biomarkers are all taken into account. Various cognitive assessments such as MoCA, Dr. Kogan, I think it's Montreal, right? What does MoCA stand for again?
Yeah, so MoCA is Montreal. There's also a SLOMS test. So there's basically a series of different cognitive tests and
Yes.
about 200 tests, blood work tests that are accomplishing monitoring of progress. So you want to make sure that once we optimize some of the components, so for example, like you mentioned, burning fat instead of burning sugar, right? So we want to make sure that once we went and put you into the fat burning zone, that actually helps you to shift you away from glucose metabolism, and that the glucose markers like fasting insulin and something we call HOMA-IR, which is a measure of combination of insulin and sugar on the fat and in the fasting blood, getting better. Actually, sometimes it doesn't. So you have to, it's really important that it's not the similar to what Dr. Yekel was describing. We are adjusting, but then reassessing and continuously reassessing. Otherwise, as you exactly pointed out, a lot of people fall out of wagons, so to speak. They think that, okay, I got better, now I can stop everything. Unfortunately, we're not there yet. We don't have a tool that I can give somebody for 6 months and their Alzheimer's gets cured. That just doesn't exist. And so often this program has to be, I would say, lifelong for the kind of, I think this is what we're seeing. You know, once we get someone more stable, we have to keep them there. And in order to do that, we have to continuously recycle the Apollo report and get the new tests. And that's the part that I think, Brianna, you were saying is very difficult, because it's a different, like, we're not used to doing this in the regular medical field, right? I mean, we're not assessing 200 tests 3 or 4 times a year. There is no format for that, right? I mean, there's no templates or frame of thought in a standard medical care that disease is so complicated that the monitoring has to be of every system on multiple of levels, and there's no endpoint to it. The system is not set up for that. The system is set up for acute care. The system is set up for periodic checks of certain basic physiologic parameters, but not to that level of complexity, which brings it back to you, Brianna, as you're mentioning. Well, let's just move on with the reports.
So the great part about these reports is when you do it on a consistent basis, and they all use the methods to put together one of these reports can be so helpful, because when you get multiple results of them over time, you can directly compare them. So I can look back at a patient's file, go down and say, hey, September 2020, they had this score on this continuum of inflammatory markers, their overall score, and the type of cognitive impairment or Alzheimer's disease they may have, and directly comparing that status over time. Same thing with the cognitive assessments, such as MoCA, BOCA, SLUMS, and as well as the CNS vitals. You could directly compare them over time to each other. And those cognitive assessments, the blood work, any kind of environmental toxins, and your personal medical history, and your genetic makeup too, are all pulled together into this very comprehensive report that Dr. Kogan and I, and sometimes even Dr. Yekel, will go over together, look through everything, and develop a treatment plan that best works for the patient's situation and their lifestyle. And then after that report is generated and we come up with a treatment plan, I make a point to meet the patient every month, if not twice a month, to guide them through this diet, through their lifestyle, answering any questions that I have that I can, and whatever I cannot, I go ahead and ask Dr. Yekel or Dr. Kogan about it. We work on we're very collaborative in this protocol, and it's very important for us to try to do our best to support the patient in whatever way possible.
Great. Can I put something on?
Yeah, go ahead.
I just want to show everybody the data real brief.
Yes.
So this is our current, not that. It's for some reason, 1 second. There we go. Can you guys see the Apollo website?
We see your screen, not the Apollo.
Oh, all right. Back to this screen. Now you seeing the Apollo now?
Yes.
Okay, so this is the actual trial result. I just want to show it to you in a minute or two. And you can see that when they did it under the controlled settings with a 10 hours a week, 5 to 10 hours a week of support time at no cost to the patients, 80% recovered from Alzheimer's disease. Now, this is controlled settings. The cost of this is exuberant. We can't reproduce it. This would cost about $10,000 a month on average for the patients. We don't have that level of funding at the moment. So, but if you look at the actual practical, this is the 84% improved. But if you look at the actual level of data, which is a lot closer to what we're seeing in our patients, we're seeing about 50% improvement, 25% decrease, and about 25% no change. Our data is a little different. We have about 50% no change, 25% improved, and 25% progressed. And this has more to do with the fact that I think our cohort is a bit older. But the biggest challenge of the entire program, and I think Dr. Yekin would attest that it's the same with the mold, is that the adhering to the protocol is very difficult. We simply don't have the level of complexity in our healthcare support systems in place. And so being able to continuously put 2 to 3 hours a day of the work into this is challenging. But at the moment, that's the best we can do. And in the next decade, I don't expect significant improvement. I don't expect we're going to have drugs. I don't expect we're going to have any care elements that will somehow break through this. The famous Adelheim is a one big disaster. It doesn't work much. It causes a lot of problems, and it costs $70,000 a year. Most likely FDA will revoke its approval because in real life experience, we're just not seeing results. And I don't expect any other drugs come up from pipeline that will dramatically change the management of Alzheimer's disease. So I think that the programs like Bredesen, and that's not the only program, it's just the one we chose to follow. There are similar programs out there that probably will be the future of the care. And as you've seen, it's sort of not that far different from what purely mold-related SIRS, systemic inflammatory response syndrome management is. So I think with that, I'm going to stop sharing. Brianna, do you want to add anything else?
Overall, we covered the programs and the management styles very well. Dr. Yekel, do you have anything to add?
No, not at this point. Thank you for sharing. And of course, Dr. Kogan, thanks for having me on.
Great. Well, let's get right off to the questions. So I'm going to, both of you guys stay unmuted. Let's start with the questions that are already in the chat, and I'll just go down, and then in no particular order, we'll answer them, whoever feels more at answering a given question, and then we'll go to see if anybody needs to unmute and ask us questions verbally. So it looks like the first question, and you guys help me out too if I miss something, but it looks like the first question here is about, is the diet different for ApoE3/4 and 4/4? No, it's exactly the same. The only difference with 3/4 versus 4/4 or versus 3/3 is that you need to be much more aggressively careful about total amount of saturated fat, because you will drive very quickly your LDL, and you don't want to do that. You need to make sure that LDL is maintained at the reasonable level. For me, it's less than 130. But you don't want to just jack it up, because if you take a lot of coconut oil or MCT oil, your LDL will shoot up, and I've seen it shoot up from 130 to 300 just taking MCT oil. So you have to be careful with 4/4 there. But some people, it doesn't happen. I think it's more complex than simply one particular factor. Brianna, you didn't really talk about Intellix DNA, but we do offer part of our program, which is not necessarily at every Apollo clinics. We do offer Intellix DNA, which is a complex genetic test that's pricey, but it sometimes cuts through some of this key elements of biochemistry. And so we sometimes can immediately get to the bottom of something that may take months, if not years, to figure out. So that's something, and that's also something that Brianna coordinates because it's a pretty sophisticated test to get organized. So
yes, they also have some good nutritional effect. They also report nutritional information on there too, which further reinforces how important it is to incorporate the genetics into what you eat and how to manage this all in a cohesive manner. So it gives us even more fodder and even more material to use with developing the ultra personalized diet and overall program that we need to develop.
Exactly. Regarding the diet, one other aspect is coming up. It's not quite here yet, but I'll mention that. So we're partnering with a new, I'm going to hold off even telling you a name yet, of the new microbiome company that's actually local and a lot better than the current existing companies, because we feel, and we're actually applying for a pretty sizable $250,000 grant from private foundation to try to answer the question. We do know there's a universal disruption in Alzheimer's disease and microbiome. We just don't know exactly how to treat it yet. So we're going to try to get this better test and then adjust the diet according to the test. So that'll be something that Brianna and I will be giving you guys updates as we learn more. For now, it's just all, it's still in a pre-clinical setting for the process. But once we get going, even if we don't get a grant, we're still going to offer because the test is commercially already available. Okay, so John, I think that's your comment, right? MRI needed?
Yeah.
Okay.
Yeah. So the question was, is the MRI needed just the standard MRI without contrast? And no, it's a very, very specific MRI. It's called a neuroquant MRI is what we run. And essentially it's got specific settings that need to be done when you go in to get the MRI. It is done without contrast, but then they take this MRI and they run it through neuroquant software. And this is going to give us all the data that we need to see to be able to evaluate for neuroinflammation. Is there any edema or swelling in areas of the brain? And is there any atrophy or shrinking in other areas of the brain? And what's fascinating about this to some degree is that you can actually recognize based off which areas of the brain are being impacted if it's more closely a pattern that would be similar to mold-related illness versus, as I mentioned before, Lyme disease or potentially PTSD or even a head injury or something of that nature. So it's a neuroquant. There's a lot of places all over the country, especially both the east and west coasts. There's a lot of imaging centers just in the DC area, both Maryland and Virginia, that can run a neuroquant MRI. So that's what we need to run if we're dealing with chronic inflammatory response syndrome. And maybe I don't know, Misha, is Dr. Koh, is this what you're also looking at for any kind of recode?
Yeah. We used to do a different test for a recode called NeuroReader, but we stopped doing it maybe about 6 months ago due to some technical issues. So now if it's all defaults to the neuroquant. And the neuroquant, the advantage is it's better covered. It's actually fully covered by insurance, standard insurance, Medicare. It is, by the way, just for those of you in district, the largest local radiology center, it's called WRA, Washington Radiology Associates. They do this test specifically. So just FYI. But let's move on. We have a lot of questions and we only have 10 minutes, so be cognizant of this. So also, is the treatment different for high risk but no symptoms people for prevention? It's a great question. So the recode is for the patients who already have cognitive disability or cognitive impairment. So it's called reversal of cognitive impairment. The pre-code, it's the system that actually allows you to prevent cognitive decline. We have patients who are perfectly normal cognition who choose to be in recode because the recode offers you a lot more thorough and aggressive testing and a lot closer follow-up. But that's a personal choice. I mean, I think you can also totally be fine with pre-code. The one thing I would say for patients who are in younger ages and they have a high risk in family history, for example, I definitely would recommend Intellex DNA because it's a much more thorough one-time shot assessment of your genetics that then can put you on a pretty significant shift in the lifestyle. That's a lot, as Brianna said, it's way more personalized than anything else I can do without that test. And, you know, we're going to see this kind of steps going forward increasing largely. And I'm sure that Intellex DNA is not the only company. That is actually a company that Bredesen recommends, and we've developed close collaborative relationship with this company over the past couple of years. So I think the next question is for Dr. Yeager. Well, actually, no, I'm sorry, for Brianna. It's, can you provide more details on a keto diet that you recommend in different types? I guess it means different types of Alzheimer's. Is that, Laurie, maybe you can specify what different types, but Brianna, can you talk a little bit more in detail about what are the specifics of keto diet?
Sure. Laurie, can you explain your question a little more? Oh, she's muted.
But while Laurie is trying to type this or let us know, maybe you can just give us a little bit more detailed.
Okay. Yeah, sure. So with this Keto Flex diet, we're trying to lower the amount of overall sugar consumption and increase the overall fat consumption in your diet. So that reduces or eliminates as much as you can any sort of bread or bread-based products. The diet differentiates between the carbohydrates you receive from, say, bread or bread-based products and the carbohydrates you receive from vegetables and fruit and almost every type of food out there. We're looking to reduce glucose specifically, which is the sugar that ketosis is trying to get rid of. With the fats, we're trying to increase, oh my goodness, such as healthy based fats, such as omega-3s. We recommend freshwater or marine based fishes, while trying to reduce not too many mercury based fish. Animal products are fine, such as eggs are fine. Omega-3 enriched eggs are fine. Also chicken. You don't want to do too much red meat because they're still trying to attenuate the amount of saturated fat and cholesterol you can get from red meat. But there's still fats that if you consume that, it will help push you into further ketosis. You have to be careful of any sort of additives to food because those can often be hidden sources of glucose. Additives such as honey or agave, or even I think it's monk fruit sweetener are really good options because they're a different type of sugar. They work better with your system to not have such glycemic index spikes as, say, your table sugar or sucrose is. The Bredesen protocol.
Maybe it's actually a good thing to actually review. I'm realizing we're going to run out of time, and I wanted to.
Okay.
But I want to come back to this. So maybe one of the future topics would be to actually go and talk about the diet here, because it is a large topic. I don't think we'll be able to cover it. I think yes. If Laurie meant, if the question meant to be, do we differentiate the diet based on your type of Alzheimer's disease? The answer is absolutely. Because for a person, let's say, with a predominant toxic, they may not even need to be in ketosis. They may just be perfectly fine in a Mediterranean-like diet and do really well without going into ketosis and just get the detox going.
Yeah.
And the other big component I would say is, yes, while most people should be in ketosis, it's not so easy. Some people have problems and they have difficulty for whatever reason. They either lose a lot of fat, a lot of mass, body mass, too much body mass, and they get concerned, or simply they just don't feel right.
Yes.
I don't know what proportion would that be, Brianna, if you have thoughts on that. Maybe, I don't know, 10%, 20% of people will have a hard time sticking with ketosis.
Yeah, I was gonna say closer to 10.
Yeah, so
yes.
There are people who can't be in it, so then you have to modify it. And then,
yes.
you know, so there has to be a degree of flexibility in that process so that, you know, we can't do other things, because remember that it's a very complex program, right? So the diet is only one component, and as you remember the slide what Brianna was walking through, there's all lifestyle pieces. It's like a triangle. You have a diet, you have an exercise, you have cognitive training, and so you can't really, if you can't get one aspect, you're going to do other things still and see whether or not the protocol is working. So. But we have more questions. We have a couple minutes left. So are anti-inflammatory treatments part of SIRS? Well, yeah, I mean, I think that's the whole point, right?
Yeah.
Joan,
I would say the whole treatment is designed to reduce the inflammation, and starts from getting out of exposure, which is causing inflammation, detoxing the body, which will reduce inflammation, and then finally VIP will further shut down the inflammation. So you could say it's an anti-inflammatory protocol.
Yeah, so real quick, Linda and everybody, yes, this is being recorded right now. So we will post it on my YouTube channel in a couple hours after it's all done. And we will send you all a follow-up email with that link. But I'll put the link in there if you don't want to wait to my channel before we end too. There is another great question from Dr. Benavides, and that has to do with a graded paced exercise. So do you have pacing recommendation in regards to exercise for long COVID patients? I think I should take that question. So there's two ways to think about this. One way is that we often send the patients to physical therapists who will work with the patient on that exact, to have a plan. If for whatever reason patient is not going to physical therapist, I have my own way of doing it. I basically tell patients to bump up the exercise by about 5 to 10% each time. So let's say you're able to walk a mile at a certain speed. So I may ask you to bump it up by 10% and then give it about a week to adjust, and then see where you go next. So you want to be super slow. I think that's basically the most important aspect of pacing, because what we're learning, there's a lot of post-exercise exertional fatigue that prolongs quite far, and that has to do with the free radical damage. So when you're exercising, you produce a spike in free radicals. The body naturally has a capacity to clean the junk up. But if that capacity is interfered with by whatever, whether it's a mold, whether it's a COVID, post-COVID, or anything else, you don't have that capacity. Your exercise will not actually boost your capacity to clean the floor. And so you have to really building very, very slowly for that to occur. Sometimes I would not allow people to get up on the exercise regime. They will stay low until they're capable of start increasing. How do you decide when? There is a little bit of trial and error. I don't think anybody has a best practice set up in that sense. I think there's still a lot of mistakes happening and we're just all learning about this. I will tell you that with other diseases, not just with mold, but with conditions like Ehlers-Danlos syndrome or EDS or autonomic instability, sometimes the essential aspect is not necessarily worrying about cardiac exercise, but really concentrating on a core strength first before you move to the cardio, because often cardio would be contraindicated. The system core muscles are too weak to carry the cardio component. And so you have to first do the basic calisthenics or some kind of a guided therapeutic program to rebuild the core muscles before you can do the cardio. So we are a minute over. Let's finish up last couple of questions, and thank you everybody. So for someone in a rural area, it may be difficult to get out of exposure. Top recs. Oh, that's a tough one. Dr. Yekin.
Oh, goodness gracious. Yeah, that is a tough one. It's hard enough to find someone who does great work in a metro setting, let alone in a rural setting. So, a lot of folks are willing to travel. I've got a couple of colleagues that I work with who are inspectors. One of them is, I believe, in Minnesota. Another one is in in Florida. They're both experts in chronic inflammatory response syndrome. I know they've both been to the DC area to do inspections for people. Dr. Kogan, we work with another guy, Dr. Soganov, who is an inspector. I don't know how big of a radius that he works with. A couple of the remediation companies, that we've worked with. I know Valor has gotten some really good, I've gotten some good feedback regarding them, although they can sometimes be a little expensive. I think it really probably just depends on how rural are we. That'll probably make all the difference in the world, because some people will be willing to make the drive and some people wouldn't. But like I said, we've had people come from out of state to do some inspections for people in more complex cases.
Yeah, exactly. And I think that the small things you can do yourself, like you can set up air filtering system in a home, and Dr. Yekel has a complex recommendations for that. And, and sometimes you have to really just isolate certain areas. I mean, if you have something in the basement that you can't clean at the moment, or you can't get rid of, you can seal your basement, or you can, bag everything in a completely airtight containers, or the plastic bags. At least for the time being, you're minimizing the exposure to the toxins coming out of that area. None of this is though, and I want to kind of finish up on this note, Jonah. I think none of this though is a foolproof, and unfortunately, we see a lot of people who think they can shortcut things, and it just often doesn't work well at all.
Yeah, well, and I would say that the Shoemaker protocol, I have seen incredible success. People ask me all the time, how often does it work? And I will tell you this, the only time I've ever seen it not work is when people don't get out of exposure, which of course is the most challenging part of the recovery, because, a lot of people take shortcuts, a lot of remediators take shortcuts. It is very complex. It's hard to make a sick home into a healthy home, and sick homes lead to sick people. And, so it can be a fairly challenging process. And so some things that might work in the short term aren't necessarily going to work long term. And that was exactly my own experience. Is I actually healed in a home where we never really fully got the basement to an ideal situation. But I knew that the minute I stopped the protocol, I was just going to start getting sick again. So even though it was good enough to heal in, it was not a home I was going to be able to stay in long term. And, so eventually we had to get out. And I think that that's a reality, is that it's very complicated. It's very complex. And the biggest mistake people make is taking shortcuts and assuming they got out of exposure when they never really actually got out of exposure.
And that translates perfectly to what Brianna and I are seeing with Recode. We get this question all the time. Well, I don't want to do this whole program. What if I do a third of it? And I like to say, look, you could try it, but the chances of success are so small that you really have to stick with the program. And I think that's part of the complexity and difficulty at the moment, because this all ends up being expensive. This all ends up being very complicated.
Yes.
Tons of time has to be spent. And, you really have to be I like to compare it to, there are people who prepare for marathon. What do we call them? Weekend warriors. That's
Yes.
So you can maybe prepare for a half a marathon like this. That's also me. But for the whole marathon, no. You have to run 4 or 5 times a week for 6 months. It's just certain things don't work. And with our physiology, the program is designed for that particular reason. Maybe in the future, we can say, look, for that person, you can just do this 5 things and they get better. We're not there yet. And I don't think when we will be there. And that also presents a challenge when somebody walks into the door, and then I'm sure Jonah is the same issue. I can't tell anybody, what do you need to do specifically to guarantee the result. I know that here's a whole program, you have to follow the program. And if you do it, then you have pretty decent chances, but I can't tell you that you can take this half of the program and expect a good result. Genetics seemingly shortcut. So the genetics, when we get genetics back, sometimes we can do a bit better, I would say, but we're only at the beginning of this. I think I have a gut feeling, pun intended, that after we get to know the microbiome testing better, we may be able to shortcut some of that work. But again, this is all theoretical conversation for the moment. You know, we need a lot more practical work and a lot more patience just to see what happens. So sorry, we'll run out a little bit. We have a little bit of technical difficulties in the beginning. I'm going to go ahead and stop the recording, but thank you everybody for coming. I will personally hang out here for a minute or two. If anybody have a last burning question they want to unmute or something. But with this, we are finishing the formal part of our talk. Thank you so much, Brianna and Jonah, for joining. Brianna and I will talk about how to do the whole thing on a diet in some upcoming future. So stay tuned for that. But also, I almost forgot, my bad. And I'm learning this, so just give me a second. I have to figure out how to put my YouTube channel link in the chat. So before we end, oh, something is not working as always. Today seemingly is an increased number of technical difficulties. I'll put that in after it should kick in a minute. So, but with that, the recording is stopped.